Bipolar Disorder by Taylor Willis. Bipolar disorder is a mood disorder that is characterized by clinical episodes of mania and depression. There's also two subcategories. There's bipolar type 1 and bipolar type 2. The first one is going to be abnormally and expansive moods and manic behavior for 1 week. They include psychotic features, and they could be in danger. Bipolar type 2 is actually going to exclude the psychotic aspect, and they go into something called hypomania. And depression is more so the problem area in this type of bipolar disorder. Here I'm just going to go over what we're going to be seeing in the presentation, including the pathophysiological process of bipolar disorder, along with the human response to the disease, along with diagnostic testing, laboratory testing, treatment plan, conclusion, and my references for this presentation. Okay, so a pathophysiological process. We know that bipolar disorder is a mood disorder, and mood regulation is where the problem is in this mood disorder, and that happens in the prefrontal cortex and the amygdala. We know that there's an alteration in connection, but we do not know a specific dysfunction that has been identified that is causing bipolar disorder. There have been notable changes within patients with the brain-derived neurochemical, the nerve growth factor, NT3 and NT4. They all indicate that the neurotrophic signaling is the molecular mechanism associated with neuroplasticity. We also know that from PET and SPECT scans, there's an increased temporal lobe and amygdala volume. Some changes could be caused by the disorder and could be from the order. That makes sense. This disease is also very genetically predisposed. Medical history and family history is actually a huge part in diagnosing this disorder. When we start discussing bipolar 1, they're going to be characterized by manic behavior. So they're going to have elevated and irritable moods. They're going to go back and forth. They're going to have just an explosion of ideas, like just so many at a time. They'll have pressures, speech. They will be euphoric. They'll have clang association, which means rhyme talking. They'll be talking in rhymes. After the euphoric feeling comes, usually they become irritable and become demanding, and they push their limits of behavior. They don't sleep because they're manic. They have excessive talking and activity, like a lot more than normal. They dress out of the ordinary, so outgoing hair, just over the top hair, makeup, and clothing. A lot of times they will become like more sexually active, which requires them to have monitoring to ensure that they don't have any, unwanted or unwelcome sexual advances to them. They're often impulsive. They have limited attention span. They have poor judgment, and they lack their insights. They will also have paranoid and grandiose delusions. They're common, but they're not required. And a lot of times, because of all of these symptoms, patients will self-medicate themselves. Okay, so this next set of symptoms can go with type 1 or type 2 bipolar disorder, and that is going to be hypomania. Hypomania, the main thing to remember is that it does not have psychotic symptoms. So the patients are not exhibiting psychotic symptoms such as presented in mania. So what you'll see in this is going to be the patient is going to be more outgoing and social, but it's not subtle. It's very noticeable by family and friends. Like, it's totally out of the norm and it's not their normal way of behaving. However, this is not severe enough to impair social or occupational manners of their life, nor does it require hospitalization. As I did forget to mention that mania is in fact a medical emergency and they do need to be hospitalized. Some complications due to bipolar type 1 is exhaustion and cardiac collapse due to no sleeping or resting. They also quite often forget to eat, resulting in weight loss, which is unhealthy. They also are psychotic, which could pose as a danger to themselves and society, as the psychosis could result in suicide or homicide behaviors. Social and occupational impairment happens due to negligence in their medication plan, or not being treated at all. Also, they could have complications in staying on track in their plans, their medicine plan, their psychotherapy, because they feel so good and they don't want to be taken down from the highs. The mood cycling in type 1 is also a lot more visible and frequent than type 2. So when it comes to diagnosing bipolar disorder, there's not any real clinical testing to be done. It's based on the clinical presentation of the patient. The patient may present in manic or depressive phase. Past medical history, including their meds and their family's medical history, is required because it is genetically disposed. We also need to know their treatment success and their resistance as well. In bipolar disorder type 1, at least one manic episode is required for diagnosis. It may precede a hypomanic or major depressive episode, but it's not required in type 1 for diagnosis. In type 2, one current or past hypomanic episode and a depressive episode. There's no mania involved with type 2. There's also going to be rapid cycling, and that includes 4 or more distinct mood changes within a 12-month period. Also, I want to note that a manic or hypomania episode is characterized by a depressed mood, anhedonia, psychomotor retardation, fatigue, excessive guilt, and recurrent thoughts of death. Like I had noted before, there's not any actual testing to do, but what we do like to do in the medical field before diagnosing is to get routine lab work done, like a CBC to get, complete blood count, and the serum chemistry. And we want to get these to, like, cross out any diseases or illnesses that could be going on at the same time. There could always be an underlying medical illness on top of their neurological disease that they're suffering from. So we want to make sure we get those all checked out. When it comes to a treatment plan for bipolar disorder, there is not really one size fits all. It's going to be very specified to each patient, and it's going to be a lifelong maintenance for most people. It's going to include psychotherapy and pharmacotherapy. There's going to be a combination of medications that they're going to work with. Most people are treated with lithium. They're going to be treated with mood stabilizers, but that could include lithium, conistolants, atypical antipsychotics, because they reduce agitation and promote sleep, which for manic episodes, that's really important and crucial. Lithium is very crucial for the serotonin and dopamine issue that bipolar disorder patients suffer from. Well, and it goes really with all neurotransmitters, so including acetylcholine and neopinephrine. There's also, you have to be really careful and really pay attention to the lithium levels in the patient, because the lithium toxicity ratio is very, very low, and it could result in death or a coma. So it's very important to pay attention to. Oh, and also that valproate is a danger to childbearing women.